Hello, I'm Sven Gudmund Hindraker and Professor at Center for International Health, University of Bergen. This lecture gives a brief historical overview on tuberculosis disease and tuberculosis control measures. Tuberculosis has infected humans for thousands of years. The oldest known evidence is this skeleton from the Mediterranean, where a suspicious lesion in the bone showed evidence of DNA from Mycobacterium tuberculosis. Tuberculosis has been known to humans for millennia, but was initially relatively rare. In Europe during the Industrial Revolution, the incidence increased a lot. This figure shows a hypothetical course of the epidemic in Europe based on scarce data. For example, Trondheim City in 1910, it was the number one killer, causing 1/4 of all the deaths in the city. When drugs against this disease were discovered in the 1940s, the peak of the epidemic in Europe had already long passed. The cause of wasting disease, or tuberculosis, was a hot debate in the 19th century. Everybody could observe that tuberculosis occurred in families, and sometimes almost a full household might get the disease. Therefore, some scientists argued that this was an obvious hereditary disease, whereas others argued that it spread among those who shared common space. Dr. Jean-Antoine Villemin in France proved in the 1860s that it was infectious by inoculating rabbits with material from sick individuals. Dr. Robert Koch in Germany studied mycobacteria, and he isolated bacteria from tuberculosis patients. In 1882, he published a paper that showed that Mycobacterium tuberculosis caused the disease. Let us look at how tuberculosis patients have been identified or diagnosed. Historically, the obvious clinical sign of tuberculosis was wasting, and it is still important. Today, in countries with little tuberculosis, the doctor may think about cancer, which may look much the same. Cough for a long time is another common classic symptom, which is again not unique for tuberculosis. However, any organ in the body may be affected by tuberculosis, and symptoms can vary a lot. Since the 1880s, a fast and specific test for pulmonary tuberculosis has been to take a sample of the patient's expectorate and examine under a microscope. This test is still in use and can be done in rural areas with little resources. This is how it looks in a microscope after preparing a sputum smear with Ziehl-Neelsen stain. The small red rods are Mycobacterium tuberculosis. This test is very specific, which means you're quite confident about a positive result. The test is not very sensitive, which means you're less sure about a negative result. Tuberculosis lesions can also be identified by chest X-ray. This has been a common diagnostic tool since the 19th century. A doctor well acquainted with X-ray can spot lesions that look like tuberculosis. A chest X-ray is a quite sensitive test, so that a normal chest X-ray is a good indication that there is no tuberculosis. Chest X-ray is not a very specific test. A positive finding can be due to other conditions. Tuberculosis lesions can also be identified by chest X-ray. This has been a common diagnostic tool since the 19th century. A doctor well acquainted with X-ray can spot lesions that look like tuberculosis. A chest X-ray is a quite sensitive test, so that a normal chest X-ray is a good indication that there is no tuberculosis. Chest X-ray is not a very specific test. A positive finding can be due to other conditions. Tuberculin is an extract from mycobacteria and was described by Dr. Koch in the 1890s. It was further developed and refined to be used in the tuberculin skin test, which tells if there is an infection by mycobacteria. A person infected with Mycobacterium tuberculosis will react with local inflammation if and where exposed to tuberculin, usually in the skin of the forearm, like the m.tb test. The result of the tuberculin skin test is given in millimeters of the skin swelling or in duration. A patient who was never exposed to tuberculosis will usually not develop any reaction when exposed to this extract. However, it is often positive in persons vaccinated by BCG and in persons infected with non-tuberculous mycobacteria, which are usually non-pathogenic. How has tuberculosis patients been managed? How have tuberculosis patients been managed during the last 150 years? Traditional treatment of this wasting disease in the 19th century was bed rest in sanatoria. Some added sunbath in addition to good food and rest. 100 years ago, surgery was a common treatment of tuberculosis. You could remove a destroyed lung or parts thereof. Other principles were to give the lungs rest. This was the idea behind a unilateral phrenic nerve crush that would leave the diaphragm paralyzed on that side and the lung less mobile. Surgery had basically no impact on the epidemiological situation, but some effects on individual patients. A vaccine against tuberculosis was developed, the BCG vaccine. This used tuberculosis strains from cattle, bovine tuberculosis. It was developed around 100 years ago and introduced in Europe before the last World War. In Norway, it became compulsory from 1948, and BCG became part of the Global Expanded Program of Immunization, EPI, from 1974. Infecting children with this non-pathogenic bacterium gave good protection against tuberculosis in infants and tuberculosis meningitis and miliary tuberculosis. A vaccine against tuberculosis was developed, the BCG vaccine. This used tuberculosis strains from cattle, bovine tuberculosis. It was developed around 100 years ago and introduced in Europe before the last World War. In Norway, it became compulsory from 1948, and BCG became part of the Global Expanded Program of Immunization, EPI, from 1974. Infecting children with this non-pathogenic bacterium gave good protection against tuberculosis in infants and tuberculosis meningitis and miliary tuberculosis. A vaccine against tuberculosis was developed, the BCG vaccine. It consisted of live tuberculosis strains from cattle, bovine tuberculosis. It was developed around 100 years ago and introduced in Europe before the last World War. In Norway, it became compulsory from 1948. The BCG became part of the Global Expanded Program of Immunization, EPI, from 1974. Infecting children with this non-pathogenic bacterium gave good protection against tuberculosis in infants and tuberculosis meningitis and miliary tuberculosis. During the last World War, Professor Waxman and Dr. Schatz in the United States of America found a compound produced by streptomycin bacteria from the soil and called it streptomycin, when it was added to culture of tuberculosis bacteria, they stopped growing. During the last World War, Professor Waxman and Dr. Schatz in the USA found a compound produced by streptomyces bacteria in the soil, and they called this streptomycin. In the laboratory, when it was added to culture of Mycobacterium tuberculosis, they stopped growing. During the last World War, Professor Waxman and Dr. Schatz in the USA found a compound produced by streptomyces bacteria in the soil. They called it streptomycin. In the laboratory, when it was added to a culture of Mycobacterium tuberculosis, they stopped growing. This compound was tested in animals with tuberculosis and worked well. It was also tested on patients and had a good clinical initial effects. Streptomycin was tested in animals with tuberculosis, and it was also tested on patients and had a good initial effects. A randomized trial comparing streptomycin and bed rest was completed in 1948 and showed a striking initial improvement in the patients receiving streptomycin, but most of the patients developed drug resistance. Another drug against tuberculosis was developed by the Swedish professor Jürgen Lehmann in the 1940s. It was para-amino-salicylic acid, abbreviated PAS. Tested in the laboratory, it inhibited growth of Mycobacterium tuberculosis, but was not as good as streptomycin. In 1950, British scientists tested a combination of the two drugs, comparing streptomycin alone with streptomycin plus PAS. They found 67% resistance in the streptomycin alone group and only 10% drug resistance in the streptomycin plus PAS group. This showed that combination therapy prevents drug resistance in tuberculosis. When drugs became available for tuberculosis, more efforts were done to find the cases. Mass radiography and chest X-ray. When drugs became available for tuberculosis, more efforts were done to find the cases. Mass radiography is chest X-ray in miniature used to find tuberculosis patients in the population, and this was done in Europe after the Second World War. This may have contributed to the decline of tuberculosis epidemic in Europe. However, this demanded lots of resources, and even with a negative test, you may still have latent tuberculosis in your body that later returns into active phase after months or years. Therefore, such population surveys had to be repeated at regular levels, typically every 2 or 3 years. What is the best examination to identify tuberculosis in patients suspected having the disease? The gold standard has been culture, but it takes up to 8 weeks to get the results, whereas chest X-ray and microscopy can be done the same day. Which one is the best to identify tuberculosis cases? This study in India investigating pulmonary tuberculosis among symptomatics showed that no investigation is perfect. Out of all suspects, 10% had an X-ray suggesting tuberculosis, 7% had microscopic findings suggesting tuberculosis, and 7% had tuberculosis verified by culture. Compared to culture, the microscope missed 20% of real cases, and few of the positive cases did not grow bacteria. Chest X-ray missed only 12% compared to culture, but 37% had actually other conditions. This means X-ray is good for screening, but not good alone as a single diagnostic tool. The microscope will miss a proportion of the cases, but those detected by this method, you can be pretty confident about the diagnosis. Initially, the combination treatment was done at Sanatoria, but a large study in India showed that Initially, the combination treatment was done at Sanatoria, but a large study in India in the late 1950s showed that if you allow them to live at home and have some arrangement for giving the drugs, you can have the same cure rate, same relapse rate, and not a higher number of household contacts infected. Initially, the combination treatment was done at Sanatoria. But a large study in India in the late 1950s showed that if you allow the patients to live at home and have some arrangement for giving the drugs, you can have the same cure rate, same relapse rate, and not a higher number of household contacts infected. The treatment with streptomycin and PAS gave good results, but a substantial proportion of cured patients had recurrence of tuberculosis later. In the 1960s, a new drug was developed, rifampicin. It had excellent effect on killing bacteria, and there was much less recurrence later, so that treatment could be shortened from a year or more to half a year. If the patients did not swallow all the correct drugs during the long treatment, this could lead to drug resistance. Even hospitalized patients sometimes took drugs irregularly. How could drug taking be ensured in order to avoid If the patients did not swallow all the correct drugs during the long treatment, this could lead to drug resistance. Even hospitalized patients sometimes took drugs irregularly. How could drug taking be ensured in order to avoid development of drug resistance? The easy and cumbersome direct observation of patients swallowing all their drugs, done by health workers, was tried with success in India already in the 1950s. This method was later, in the 1990s, included as one of the important points in the comprehensive strategy called Direct Observation of Therapy, short course, the DOTS strategy. In the 1960s and 70s, with an effective treatment available, scientists discussed how tuberculosis could be controlled. In developed countries, it was already under control. But how could it be controlled in poor countries with poor infrastructure? Could vaccination make the population immune and then inhibit the epidemic? Vaccines seem not to have much effect on the most contagious type of pulmonary tuberculosis. Another available strategy was to eliminate the sources by finding the contagious patients and treating them. But to do this in a poor country seemed to be an impossible task. And would it have any impact on the epidemic at national level? In the 1980s, Dr. Styblo calculated based on epidemiological principles that if you detect 75% of tuberculosis sources and cure at least 85% of them, you should have an effect on the prevalence of tuberculosis. This was before the HIV epidemic had taken off. A tuberculosis control strategy was developed by Dr. Styblo. There are 5 main points. 1. Political commitment. There must be a stated priority about tuberculosis in the national health strategies, and this should be evidenced by a separate budget. It must be countrywide and should involve most health facilities in the country. 2. Diagnosis. The strategy should identify the most contagious sources by microscopy or other method available. 3. the treatment must be a standardized combination therapy with direct observation of drug taking to avoid drug resistance. 4. There must be an uninterrupted supply of drugs and materials. 5. There must be routine recording of all suspects investigated and all cases detected, and a follow-up of each case and regular reporting to the program. This program was successfully piloted by Dr. Styblo in the 1980s in selected poor countries like Tanzania and Malawi. A tuberculosis control strategy was developed by Dr. Styblo. There are 5 main points. 1. Political commitment. There must be a stated priority about tuberculosis in the national health strategies, and this should be evidenced by a separate budget. It must be countrywide and should involve all health facilities in the country that support this strategy. 2. Diagnosis. The strategy should identify the most contagious sources by microscopy or other method available. 3. The treatment must be a standardized combination therapy with direct observation of drug taking to avoid drug resistance. 4. There must be an uninterrupted supply of drugs and materials. 5. There must be routine recording of all suspects investigated and all cases detected, and a follow-up of each case and regular reporting to the program. This program was successfully piloted by Dr. Styblo in the 1980s in selected poor countries like Tanzania and Malawi. The global tuberculosis epidemic seemed actually to be coming slowly down in the 1970s, but then in the 1980s a new challenge appeared. The HIV epidemic changed the world, especially Africa. This figure shows the number of new HIV cases by a geographical region from 1980 to 2000. The HIV epidemic had a devastating effect on the tuberculosis situation, and it increased the tuberculosis burden a lot. In many countries in Africa, the number of tuberculosis cases increased 5-fold, like this example from Kenya. Since the year 2000, some new tools are available to detect tuberculosis. One test investigates patients' serum antibodies against tuberculosis and is called interferon gamma release assay, IGRA. A positive IGRA test indicates that the person has been infected with Mycobacterium tuberculosis, but does not say whether the person has got tuberculosis disease. Another test can detect traces of DNA of Mycobacterium tuberculosis in, for example, sputum sample by using nucleic acid amplification test. Even dead bacteria will be positive in this test. In the 1980s, tuberculosis affected mostly low and middle-income countries, but was regarded as a very small problem in many Western countries, mostly affecting old people who were infected as children and developed tuberculosis later in life. Tuberculosis was often ignored by doctors and politicians. One issue brought attention to tuberculosis in the West in the late 1980s. An epidemic of multi-drug resistant tuberculosis in New York. Large investments and greatly improved diagnosis and follow-up brought it under control. In 1993, WHO declared tuberculosis a global emergency and suggested a global strategy to fight it, the strategy that Dr. Styblo had tested in several countries. In WHO, they called it the DOTS strategy. The DOTS strategy was updated after 2000 in the global Stop TB strategy in slightly new versions. Then in 2016 it was replaced by the End-TB strategy. All global TB control strategies are based on the 5 basic principles of DOTS.